Angina.
Claudication.
Right.
Angina is only for the heart. Okay, so peripheral pain because of lack of blood flow is called claudication. It's often referred to as intermittent claudication because it will only come on with exertion in most cases. So the patient starts to walk, again, they reach a certain exercise intensity, just like with angina. They'll start to have pain, usually they'll report it in the calf and the distal leg. And then you reduce the intensity and the pain goes away. That's claudication. DVT, the pain would not go away when you change the intensity. Same with radicular lumbar pain. It will go away if you change lumbar position, but it will not go away if you change exercise intensity. Okay, there's going to be pallor, increase the paleness of the skin because it's not getting enough blood. Over time, if the distal areas are not receiving enough circulation, the hair will stop growing. So you'll see lack of hair. All of these we have risk of skin breakdown, and that's why we're starting here to help us go into wounds. Get excited to see lots of disgusting pictures.
Nice.
We're going to have decreased sensation because the nerves aren't receiving enough blood. If you perform a capillary refill test, it will take longer to refill. And then we're going to decrease sensation again, really emphasizing that part. When you take peripheral pulses, they will be diminished. We're going to refer to a test called an ABI, or an ankle brachial index, which essentially compares your brachial blood pressure to your lower extremity blood pressure. And if there's enough of a difference, it means you're not getting enough lower extremity circulation. The skin will also be very dry. And we're going to perform a test called the dependent Ruber test. And if that's positive, again, that is indicative of arterial insufficiency. So dependent Ruber. Okay, venous insufficiency. Kind of the opposite of arterial insufficiency. They have no problem getting blood down to their lower extremities, but they now have an issue getting that blood back up to the heart. Okay, so veins are, we're still supposed to be a little bit flexible. So they can become a little bit stenotic, but usually the issue is these valves become incompetent. There's been high blood pressure for so long that the veins become stretched out and the valves become weakened. So they're supposed to be sending blood back up to the heart, but every time blood passes through a valve, the valve will close to prevent backflow. Once those valves can't close anymore, blood will just pool in the lower extremity. So what's going to be the main sign we're going to see? Peripheral edema, and it's often pitting edema.
You have discoloration as well, like the lower extremities?
Yes, and discoloration, which we're going to talk about in a second. So they also will have pain, but this pain can be relieved by positioning. Okay, so the pain here came on with exercise intensity level, where the pain in venous insufficiency is going to change with position. So what position will relieve their lower extremity pain? Leg elevation. You get that blood back to the heart, it's not going to be painful anymore. Okay, so they have dependent pain. One of the first things you teach the patient to do is to elevate their legs at the end of the day. We also have to get them moving because we need the calf muscle pump working to get the blood back up to the heart. Now they have discoloration. Instead of pallor, we have what's called hemosiderin stains, which is actually a browning of the skin. It's like a reddish brown, and it comes on in spots, or just specific areas. Okay, so that's called a hemosiderin stain, and it's because there's there's a whole bunch of dead red blood cells just sitting in there. Like I said before, they're also going to be prone to skin breakdown. They also will have diminished sensation. Like we mentioned, there's going to be a lot of peripheral swelling and pitting edema. And when we elevate the legs, the pain will diminish.
So like my grandma has really bad vascular issues. Like, I don't know what exactly, but she gets it so bad, like in her feet, it'll be like purple almost or blue. Is that the same as hemocydin staining, or?
No, that's just a lot of blood pooling.
Okay, and that could be either venous or arterial?
No, that's probably venous.
Okay.
No, arterial is just going to be tail.
Okay.
Okay, lymphedema. Oh, yes, please.
Can you have arterial insufficiency with the PTAP insufficiency?
Yes, you can have both.
So raising the leg won't be.
Yeah, so if someone has arterial insufficiency, never, ever, 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 ever elevate their legs. Because you'll make it worse.
If you have so much pain with the venous insufficiency.
So, if someone has arterial insufficiency is actually considered more of an emergent situation than venous insufficiency. Venous insufficiency is kind of chronic and there's a lot of physical interventions you can do to treat it, versus arterial insufficiency, if it's bad enough, they need surgery. So, if this is diagnosed, if they haven't seen an MD about it, then they need to right away because it needs to be treated medically. Because otherwise, they're at risk for amputation. Okay, so lymphedema. The lymph system is, I always think of it as kind of like the sister to the venous system, where they are kind of working in the same way of returning fluid to the heart. Except they are returning what type of fluid in the lymph system? Lymph fluid, which is? Interstitial fluid. And it eventually dumps it back into the venous circulation.
The vena cava.
Okay, so we're going to have a lot of similar signs and symptoms to venous insufficiency, where there's going to be a lot of peripheral swelling. And again, it will be assisted by elevation. The swelling is often a little bit more dramatic than in venous insufficiency. And this, again, the skin appearance and the type of skin breakdown that they are prone to will be a little bit different. We'll look at. Okay, so a little more specifics about arterial insufficiency. So like we said, it's lack of adequate blood flow to that area. It is a specific type of peripheral vascular disease. So PVD is just a general term for any vascular issue, usually in the lower extremity. Okay, and then PAD is arterial disease. Okay, so what are risk factors related to arterial disease? Smoking is number one. They already have a history of cardiac disease. They likely also have some sort of, at least some degree of arterial insufficiency. Because cholesterol doesn't just build up in our coronary arteries, it builds up in all of our arteries. Patients with diabetes have an increased risk of developing arterial insufficiency, especially uncontrolled diabetes. Okay, the high levels of blood glucose eventually will degrade the nerves and the capillaries. If a patient has hypertension, some sort of kidney disease, high cholesterol, obesity, and sedentary lifestyle. So again, majority of the patients with arterial insufficiency do have diabetes. We'll talk a little bit more about the wounds, what they're going to look like later. As we said, there's decreased peripheral pulses, pallor, and we're going to do the dependent Ruber test. So write down what this test is. So what you're going to do is you're going to take the patient's leg and elevate it for 30 seconds. Okay, so if you have them in sitting at the edge of the bed, if they have the hamstring flexibility, you just straighten the knee for 30 seconds. Then you put the foot back down in a dependent position. And if it immediately has a huge flush of redness, with pain usually, that would be a positive dependent Bruber test. Okay, so it's a symptom of arterial insufficiency. Everyone's legs will get a little bit Bruber going back down, but it would be very severe and quick and painful. Okay, so this is an example of what an artery would look like, and it has atherosclerosis and plaque buildup. Therefore, the pathway is narrower, less blood can get through. They have peripheral arterial disease. Okay, so like I said, the pain that they have is usually aching of the lower extremities during walking or during some sort of exertion. And that's called declaudication. They're also going to report symptoms of cramping at rest and at night, because they're going to be supine, which again is going to slow the circulation down to the lower extremities because they're in a less gravity dependent position. Okay, so it's medically diagnosed with a Doppler ultrasound. So they actually look at the arteries to see if they're occluded. And then like I mentioned, there's also what's called an ABI test where you compare the brachial blood pressure to the ankle blood pressure. And if the ratio is diminished, then it's positive for arterial insufficiency.
Is that ultrasound run completely different, like what did you learn about that, or is it something completely different?
No, only physicians do it.
But if somebody's having,
Tibial artery, that would be the,
I
ankle?
think a lot of different ones.
Maybe one.
Yeah,
Like an artery.
like an artery and artery.
so if somebody's having pain at night in their legs because of lying supine, you tell them to lie in a leg-dependent position?
No, you say go to the doctor, you have arterial insufficiency, it needs to be treated. There's not much we can do to help someone with arterial insufficiency, they need to get it medically treated.
How do we
So
know
if
if
it's
that's
already to that point that they're having pain, it's already severely occluded, and they're at risk for one of those clots coming loose,
Yeah.
ending up in venous circulation, again, risk of amputation because of lack of blood flow.
How do you know if it's not like a potassium deficiency or something? And they're just having cramps in their legs.
Well, what would you do to test that theory?
Give them banana.
Have them start taking potassium, see if it changes.
Yeah.
If it doesn't, and again, put them on a treadmill, what intensity does it come on at? Decreasing the intensity, does it go away? Versus maybe have them go uphill, they're in lumbar flexion, they're gonna have less lumbar radiculopathy pain. So there's a few different little things you can do for differential diagnosis. Okay, so let's talk about that. Okay, so this is what I've been saying, exercise and peripheral arterial disease. So if the arteries are occluded, muscles aren't going to get enough blood. So if you increase exercise intensity too much where this pain comes on, it means your muscles are asking for more oxygen than the arteries can supply. And that is a sign of ischemia, which we don't want to have happen to our patients. Okay, so if we are exercising, A, we need to make sure they're already seeing someone medically. If not, we're going to refer them. Okay, so if you suspect it, you would talk to the PT. But two, if they're already being treated medically, then you have to make sure you keep that exercise intensity below the level of when that pain comes on, just like we do with angina.
massage help?
You need to make it more obvious.
I actually didn't write this. Okay, so like I said, interventions, we need to make sure that they are being treated medically. That's number one. Number two is education on lifestyle modifications. Stop smoking, get your diabetes under control. You need to exercise, but you gotta exercise below the intensity of the claudication. And if they have a wound, then we will be treating the wound. But other than that, there's really not much we can do. Okay, so number one, medical referral. Number two, lifestyle modification. Number three, aerobic exercise at a low intensity. Number four, treat their wound. It's gonna be black and dry. Unless it becomes gangrenous, then no. Okay. Okay, so these are just two examples of interventions. Similar to coronary artery disease, they'll have an angioplasty where they basically just put a catheter in the artery to open it up, and then they may leave a little cage in there to keep it open. Or they may do a bypass where they take another vessel and they bypass where the occlusion is.
How long do those last when you put them in?
I don't know.
I was just wondering if they have to use it for sure.
I don't think so. But probably if a patient didn't modify their lifestyle at all, then they'd be at greater risk of degrading.
Wait, let me ask my dad.
Does he have one?
He's a heart surgeon.
Oh.
I did too.
Me too.
Yeah, me too. Me too.
Who's recently done?
I knew there was something about you.
You guys are 22? Yeah, me too. Me too. Oh, you guys were, yeah.
Okay, so Raynaud's is actually considered another peripheral vascular disease. It's kind of a different type. It's where you have vasospasm in response to cold. So you have extreme pallor in the fingers, so just stay away from the cold. Okay, that's it about Raynaud's. Venous insufficiency. Okay, so here are some pictures. This one has it on the right, so I don't know if you can see the Achilles right here, it's well defined, and then here it's just completely swollen. Okay, this is actually, well, an extreme version of a varicose
Bless
vein.
you.
It's called a tortuous vein, because it looks like it's being tortured.
Bless
Here, again, it's really hard to see, but this is dryness and the hemosiderin stains. And this is an example of a venous ulcer. I'm children, they get much worse. Okay, so like I said, with venous insufficiency, often referred to as chronic venous insufficiency, you're not getting the blood back up to the heart and it's pooling in the lower extremities instead. Okay, so things that can lead to chronic venous insufficiency, the older you are, the more prone you are to it. But sedentary lifestyle, obesity, unfortunately pregnancy, long hours of standing or sitting, and again, high blood pressure. Add that in there. Okay, so it's almost always bilateral swelling of the lower extremities. It could be in some cases unilateral. This is going to reduce with elevation. In early stages, it can completely go away with elevation. The patient is going to have skin itching, fatigue, achiness, and heaviness in the limbs. And again, that achiness is going to be relieved by elevation. Okay, we're going to see the hemosiderin stains. Lipodermatosclerosis. Sclerosis is a thickening, so you'll see some thickening of the skin. And fibrosis, again, is another form of thickening, and the skin becomes less compliant, more hard. You have an increase in distal temperature of the legs. And again, lots of edema. Okay, here's a venous ulcer. And we're going to talk about that a little bit later. But notice how, look at the borders here. They're kind of all over the place. It's not really well defined. Everyone look at it. Look at it. I know.
So they're just in sideline position?
No, this is a venous ulcer. It's because of lack of venous circulation. It's not a pressure ulcer.
So it doesn't. I would think it would become necrotic, does it not?
Arterial does.
Oh, I'm sorry, yes. I have it.
Okay, so again, you have increased risk with diabetes, hypertension, congestive heart failure, and DVT. In terms of diagnosis, again, it'll be diagnosed medically, but a big thing is that if elevation relieves the edema, then it's venous insufficiency. Okay, so with chronic venous insufficiency, you are at increased risk of developing a DVT because the blood's just sitting there, so it could potentially clot. You do have to know this test. Hohmann's sign is the test for DVT. And it looks very similar to the Thompson test, where you test for Achilles integrity. So essentially you squeeze the calf, and if it elicits tenderness and pain, and there's localized redness there as well, that's considered positive for DVT. You send them to the emergency room right away. Okay, because if there's any risk of there being presence of a clot, you don't want to be the one who exercised them and then they ended up with a pulmonary embolism and died. So I had a patient come into the clinic. It actually wasn't my patient. But they were being treated by the PTA on site, and I was the only PT there. And they came in, and it was a new onset of calf pain. There was localized redness, and the Hohmann's sign was positive. So we said, bye, go to the ER, right across the street.
You just squeeze the calf.
Yeah, so the PTA found it, brought me over, and then I confirmed it. And it's like, you can't know for sure, but if you got all those 3 yes, that you're not going to mess around with it. Because the guy was kind of like, really? Like, that seems extreme. And we explained, you know, why it was a big risk. Yeah. We've also had a patient, like, come into the clinic while they were having a heart attack. He thought it was indigestion. It wasn't. He'd been having a heart attack, like, the whole weekend, too. Okay, so there's a lot we can do as physical therapy interventions for chronic venous insufficiency. A whole bunch. So number one is we have to manage the edema.